to make sure that the most recent progress in the management of patients who are needing urgent care are transferred to you. So I will give the mic to Pierre, who will introduce the session. Pierre.
Thank you, Professor Loisance. This session is aimed on a very severe patient that will be injured by, let's say, modern weapons. My aim is to give you information to various levels. Some information are really basic, but that means everybody can use it, and others are more specialized. But anyway, anybody must share that because it's the philosophy, the way to manage the patient, the way to do it. So we'll go back to basic principles, but also to see more specialized thing, a more recent organization and recommendation in that kind of care. So I will share now my screen, which is always a difficult period. So I hope it will work immediately. And then if I can share the screen, you may see the
Good.
presentation.
It's okay. We can see.
Yes. So in full
Yeah.
screen now. Is that okay?
It's okay.
Yes. Perfect.
That's great. That's great. Very good organization. First shot, and we aim the screen. So emergency management, penetrating trauma, hemorrhagic shock. That's the idea. A quick reminder about the fact that this is related most of the time to injury that are injury related to very specific weapons. Unfortunately, modern weapons are terribly, terribly dangerous. And the problem is that the high velocity missiles and weapons, they create a lot of energy. And this energy, when it encounters the body, it creates a lot of lesion. So the first is high energy bullets and the impact on the human corpse. The second point is that it's not only the energy, but it's also the way this bullet will travel in the human corpse, and it gives a lot of problems. And one of the most difficult things we have to figure is the fact that it creates a cavitation effect. So it's not only the trajectory of the bullet, it's the fact that a lot of energy will be dispersed, will be sent to the body and create a lot of internal lesions. So it's very difficult to see externally what happens. And obviously, many of you are very well used to see patients like that with a small hole at the entrance of the bullet, a large impact inside, and also a large also wound, but at the exterior, at the exit of the bullet. So you see that the bullet may yawn, turn, and that the cavitation effect will be different from a weapon to another, but in any case, it's something that creates a lot of injury inside. This is the first point, it's the bullet, but also most, and sometimes at the same time, they have also consequences of the exploding weapon. And again, the blast is well known, but it's still something extremely dangerous when associated at the bullets, creating a complex internal problems. You know that the blast, there is several mechanisms, and primary, that means the explosion, the blast wave. It's something that shrink the structure inside the human body. The second point is that the corpse will be projected, and the tertiary, that will be the fact that they received also a lot of projection and the effect of smoke, burn, inhalation, poisoning. And if you do that in a confined environment, in terms of result, is something that creates a lot of complex injury. So the aim of this slide and the aim of mixing explosion and bullet is to say you have to deal with complex patient, and even if you know the history of the patient, that does not mean you are able to foresee to expect injuries precisely. There will be a lot of possibility. The second point is unfortunately a point that we are sure of it for now many years. Globally, what kills patient early, it's hemorrhagic shock at the pre-hospital phase. And clearly, it's also the place where you have the most possibility to save life by organizing care, simple care, but very effective to stop the hemorrhage. And that's one of the major points of this course today is to review the way we can stop it and stop it quickly, because it's a matter again of possibility of care and efficient care for all these patients. You see, more than 50% of the patient will have hemorrhagic shock and die quickly. The second point is also something that we have to consider. It's not only the blood loss that is the problem. If you have blood loss, you replace blood and it works. No, it's the fact that when you create blood loss, this will create a very, very vicious circle. And if you cannot stop quickly the hemorrhage, you have the blood loss and also the consequences of the blood loss that became by itself a new major problem and a very vicious problem. And so everybody, from the EMTs on scene to the best surgeon, must have in mind the fact that hypothermia, acidosis, and coagulopathy, these three things work together and kill together. So we will work a lot to stop the bleeding, but also to avoid these three problems that are clearly working together. And everything, even if you carry out some decent treatment for the victim, everything may mix this idea. For example, if you have the blood lost, you will give fluid, but if you give too much fluid and you give saline, you will increase the death triad because you will create the coagulopathy. If you are doing that, you also lose the clotting factors. If you do not oxygenate the patient, you'll have more acidosis and so on. So all these factors, they are working together, and unfortunately, they are producing a very, very, very deaf organization, coagulopathy, hypothermia, acidosis, and if you do not conduct the treatment in the right way, you will have these three factors that will increase even if you treat the patient. So clearly, everybody was active. And we will see that it's not so complicated because working against the blood loss will be some mechanical measure and taking care of hypothermia, including hypothermia in a country with a very hot weather. Hypothermia is then hypothermia related to the physiology of circulation, not to the weather only. Indeed, in cold country, it will be worse. So for many, many years, and I think that your surgeon have been trained on that, but this has to be also part of the background of any healthcare provider in these circumstances. The fact is, we must do in emergency for this kind of victims something simple and effective. And that's why the way of damage control appears in the medical language, because damage control is not at all something that is medical at the end. It was something due to the Navy, and the idea of the Navy was very simple. If your ship is torpedo, you have to keep the ship afloat, and then you repair the ship. If you are unable to repair it, it will sink, and there is no discussion. And for the human body, it's almost the same thing. If you cannot stop the bleeding, if you cannot take the first measure, the patient will die quickly, and no way to repair the core. So the aim is to keep the ship afloat, and for us to preserve the life of the patient by making simple things as quick as possible. And this will go from the hospital care, the first few minutes, up to the most sophisticated care, days after. So the damage control idea is not to repair and to go to what in Latin we say ad integrum, that means repair everything perfectly. No, it's to do several sequences of surgical and also critical care period that makes the patient survive and gives the possibility to finally repair it in the best condition. So damage control will be in surgery, but damage control will be out of the surgical ward. And that's the point we will develop today. That will be on field, on the scene, and also anytime you have a medical contact in order to perform resuscitation and the possibility to have limited resuscitation but efficient efficacy. And the two words I will address clearly, that will be doing some control hypotension, stop the bleeding, and have an hemostatic resuscitation. That means correct the coagulopathy and correct the lethal free as we have seen before. That means the hypotension, the fact that we have the acidosis, the fact that we have the blood clot that are not going, coagulopathy. Okay, I hope that all these points are clear by now. We will go quickly to the fact that we have worked a lot in France on these chapters, because in our system, we have decided to promote the damage control from the pre-hospital phase and all the way along to the patient pathway. And the important point is that some method that can be taken on scene, on field, sometimes during combat care, they are almost as important as complex surgery. So what we have worked with the French Army, with the French EMS system, and with a lot of specialist surgical, is that there will be a pre-hospital phase, there will be a phase in the first surgical facility. If it is a trauma center, it's okay, but that may be also a field station with only a surgeon and an anesthesiologist. These 2 points has to be clearly shared, and the repartition of care is done between them. And all the way long, you take care of the temperature, the acidosis, and the coagulopathy. So you see a continuum and various people intervening in various environments to provide the same result. So if you see that in your organization with the resources that are available for you, you will have several interventions provided by various personnel, sometimes unskilled, sometimes very skilled, and to the nearest facility, that it will be also civilian or military practice, never mind. And this is something that will be used for single case patients, very severe, but also for mass casualties. So damage control is not mass casualties management. Damage control is a way of managing the patient, a way of thinking about the result you can obtain on the patient. And the fact that we have a lot of patients renders damage control even more efficient, because it saves also time by making the first management simple, saving time to treat other victims. That's okay for you, Dr. Oka? Okay. So let's go to various points, and we will develop some of these points, because we have tried this morning to have sometime discussion about physiology, but also very simple things that will be interesting for everybody. And what we used to say is that a surgeon must be able to operate a complex patient, but also to set in place a tourniquet if it is needed. And that's the same for the critical care specialist. So first of all, damage control and extremity injury. And you see a couple of equipment you see in this picture that are really important and that will save a lot of life if they are well used. And indeed, the first one, I have put it in orange, it's the tourniquet and the use of the tourniquet. And today we'll have a small video on this tourniquet to be sure that everybody can do that, even closing his eye, able to insert the tourniquet. And also having an update on the tourniquet, because tourniquet has been recently used a lot in other conflict, and more particularly in Ukraine, and adverse effects are possible. So we have to say again and say again that tourniquet is something wonderful, but if it is misused, it also creates a lot of injury, secondary injury. Okay. You see also compression bandage. There will be a small video on that. And you see one tourniquet set in place. And clearly the combat tourniquets are the best, but any tourniquet that have the same effect, stop the bleeding, will be interesting. You'll see a video later on that. I remind you also that there is the possibility to use a lot of compressing bandage for the damage control. And the fact is that they are now available with goes impregnated with procoagulants, which is clearly something that will limit the bleeding, and limit the bleeding is part of the thing. And there will be also the possibility to use clamp or other thing like that. When the hemorrhage is not simple to compress, for example, you may have a lot of bleeding in the pelvis fracture that will be open or not open, but a lot of blood there. So stabilizing this kind of fractures is extremely important. There will be a short video on that also. Dressing, hemostatic agent, cement that you insert in the open wound, that will be something that will allow the possibility to limit the blood loss. And all these things must be used when needed for the most severe patient indeed. And the second point is now, if we are able to stop or able to limit the blood losses, you have also now the aim of increasing the blood pressure to limit the ischemia and the acidosis that is, in fact, as I told before, part of the lethal triad. So the most important point is here, the damage control means you do not restore the blood pressure to the normal level. That's not the aim. The aim is to have, as soon as possible, enough perfusion to limit the coagulopathy, and using colloids, hypertonic saline, other things, we'll see that we can also use blood products when available. You have an endpoint that is having a radial pulse, and that's enough. If you do that, and if you inject the volume loading needed for that, having the radial pulse means you will not have ischemia in all tissue, and that's very important. For that, small volume loading, but adapt. Not a lot of colloid. Hypertonic saline, for example, is good because it's limited volume and good effect. But isotonic saline, large volume of saline infusion, they create a lot of problems in terms of coagulation and also respiratory distress. So you add to that vasoconstrictors. It may be ephedrine, that is the best. It's not expensive. But also you can use norepinephrine in continuous infusion or epinephrine in continuous infusion. Small infusion, but clearly making constriction that will limit the blood loss from vascular injuries, mostly venous vascular injury, and in the patient. Next point is to understand that clearly the hypotensive rehabilitation means survival of patient. This has been done in many experiments. That's one of the oldest, but still the most important. You see that if you have a moderate hypotension with a mean arterial pressure of 40, that means only having a radial pulse palpable, this is the best way to survive of the hemorrhage. If you have an objective that is higher, the result will be poor. And indeed, if you have no objective at all the patient die quickly. So you see clearly mean arterial pressure up to radial pulse, and this can be done by anybody in the line. As soon as you can have the possibility to add coagulation factors, that's also an important point. And that's clearly the way to fight against the coagulopathy is to give factors. There are a lot of possibilities to use factors. Indeed, the best is the possibility to have fresh plasma, frozen plasma, to have wolf blood. There is also, it has been developed in France, and we use it in civilian practice, dried plasma that has no problem of conservation. Unfortunately, it's expensive because it's not produced in a large way. But according to the available resources, as soon as possible, if you add factors for coagulation, it will be important in terms of prognosis, the possibility to survive and to save the patient. Next point is this small bottle of tranexamic acid, which is something that is not expensive. And this is clearly now the possibility to activate coagulation, procoagulant action. And we inject systematically to all the victims now of severe trauma that is in civilian or military practice. Anyway, all severe trauma that arrive to the hospital now, they received before 1 gram of Hexacil. Hexacil is the name of the brand, but it's tranexamic acid with an infusion in 10 minutes, and then followed by also another dose in hospital. So that's really something. I think Professor Loisance, that is many times has operated patient in shock and complex shock, is also promoting the idea of giving procoagulants to the patient at the time being. Next point, ventilation. Ventilation and the simple management of ventilation. We will explain later how to mix all this together, but opening the airway, that's basic of EMTs. If possible, oxygen, as in. My aim is tension pneumothorax. Tension pneumothorax is a killer, and tension pneumothorax must be clearly assessed as soon as possible, and the treatment will be a field thoracostomy. That means making a hole, and you use the hole, you set in place a special bandage that makes the patient have the air going out of the chest, no more tension, no more shock. So clearly look for tension pneumothorax as soon as possible. Then for more complex patient, tracheal intubation, respiratory failure will be organized in special units. Ventilation, blood, we have seen. Next point is hypothermia. Probably hypothermia is something that is constantly underestimated. It's incredible, but it's constantly underestimated. So taking care of the patient, using special blankets, possibility of making the patient do not lose temperature is extremely important also. And this, as I told you before, hypothermia creates coagulopathy. 1 Celsius degree, 10% decrease of the hemostatic power. It's enormous. It's terrible. So clearly, you have to rewarm by all means patient and to stop the loss of heat from the patient, make the patient stay as warm as possible all the time. And if needed, it's what we do in cold places. We use as soon as possible, heat in blanket. And during operation, during the operating room, also the hypotension needs a control of hypothermia. So clearly, take care of that. And this is not complicated. It's only the fact that it is constantly underestimated. So quick word about the anesthesia, the analgesia. That's not the aim. And if you want a special course on that, indeed, it's part of the thing we know very well and we practice on many circumstances, is the fact that if you use medication and a medication to reduce pain or to sedate the patient, you have to reduce the doses in this very severe patient. This has been observed, Professor Loisance, I think 50 or 60 years ago already, but it's still a major problem. If you give full dose of hypnotics to a patient in shock, you kill him immediately. To give you the historical idea, it's the Pearl Harbor bombings where they used the first drugs that was at this time pentobarbital. Pentobarbital at heavy dose have killed a lot of sailors because they do not know at that time they have to reduce about 2 or 3 times the doses of the produce you use in order to avoid deteriorate the hemodynamic status and the shock. The only thing that works without, let's say, adverse hemodynamic effect is a muscle relaxant. You do not modify the dyes. Cura, modify, muscle relaxant can be used at high dose. When you have an overview of that, the problem will be also that you may be very near the scene, and the problem is to send the patient to the nearest surgical facility or the nearest facility when you can provide more care. Indeed, in many circumstances, you use the helicopter. You don't have helicopters, and in civilian practice, you cannot land also helicopters. So that means you have to provide care during transport. The possibility also to make the transport as short as possible. I say the possibility because it's not always possible to do that. And we'll see the impact on that, on the fact that you have to deal with the tourniquets and the duration of the tour. Then when you arrive in hospital, the field surgical unit, the trauma unit in civilian practice, then the patient may have the possibility to receive the plasma, the platelets that have the control of the coagulopathy, and the surgical team is ready to perform a special organization of surgery. I think Dr. De Gozzi told me that he have done a course on that in past years. The important point is to understand that the first part of the surgery will be in damage control to stop the hemorrhage, and then the hemorrhage is stopped to resuscitate the patient, to control coagulopathy before making more complex surgery. Because if you do the complex surgery with a patient with a coagulopathy and is in shock, the result will be poor. But if you stop the shock and then repair the patient, you will do that very more efficiently. So you see in this way, there is a pre-hospital care. Pre-hospital care takes you to first surgery, first operation. Then you take the patient to critical care. You stabilize the patient in terms of coagulation, blood losses, and so on, and the patient goes systematically again to the operating room. And the fact of organizing this clearly makes the possibility to treat a lot of patients and also to organize your team to perform that, and the possibility to have all mass casualties or any patient treated in the most efficient way. That's the basic of damage control. Damage control doesn't mean full reparation at the time. It means you organize the reparation in 2 or 3 steps in order to save the life and then to have the final, definitive, and repair, anatomical repair. So that's not my point to explain to the surgery, but I will go back now quickly to, in order to make things more visual, quick videos about 3 systems we have selected, considering that they are very interesting. And so I show you a quick video. I hope the transmission will be well. It's a video about the tourniquets. It's in French, but we have the off. This is the tourniquet. The tourniquet, they have several models are existing, but they work exactly the same with the same component. You see the Velcro strap. The Velcro straps is set in place on the limb, and you see the Velcro on the buckle, and the pressure is increased by turning this windlass, and the windlass will stop the blood perfusion. So in this arm, look the way it is set in place. Use the right face of the tourniquet, set the tourniquet in place, begin to tighten it, and it is at the upper part of the limb, upstream the hemorrhage, tightening manually first, and then after that, twisting 2 or 3 times the windlass to increase the pressure and to stop the bleed on the wound. Then you clip the windlass, you strap the Velcro part, and then you close the tourniquet, and you see there is an indication precisely of the time you have set it in place. This is very important, the time of putting the tourniquet in place. You check that there is no more bleeding. Stop the bleeding is the aim. Sometimes this tourniquet may be used with 2 tourniquets set in place to stop the bleed. Anyway, the important point is to stop the bleed and to check there is no more bleeding. Then, the last and important point is that the use of Gaviro of tourniquets must be controlled, and consequently, at the end of this course, we'll have an update on that, precisely assess the adverse effect of prolonged use of tourniquets in non-severely injured limbs. Well, we have selected also another short video. Okay, not this one. Next. Okay. This is on compression dressings or pressure bandage are probably the most effective way to control an hemorrhage. You see the two parts, the white face you apply on the wound and a buckle or a plastic frame. Then you set in place the white part just where it is bleeding, and then you strap and you insert the strap in the plastic buckle or the plastic frame. That will help maintain it. You reverse the strap then. So this helps you to increase the pressure on the wound. And then you continue to stripe up to the end of the bandage. And when you arrive at the end, you set in place the two clips.
Ce crochet va terminer l'installation.
This is not a tourniquet. You have to check the pulse, but you have pressure on the wound.
C'est un pansement compressif, en aucun cas un garrot. Donc je m'assure.
And then you have the wound dressed and under a pressure. The pelvic binder or the pelvic belt is a simple that it's used to compress the pelvis and limit retroperitoneal hematoma if there is a fracture. You see the component? There is a large part that will be inserted under the patient. And indeed, there is several sizes that may be adapted to the patient. Use also a wrap.
Nous allons vérifier qu'il n'y
ait
You insert the strap in the buckle that will help to tighten and to maintain the pressure. The patient is lying, the victim is lying, and then you check that there is nothing in the pocket, for example, that can hurt when you will apply the pressure. So you remove the belt, for example. Then there is a special procedure to set in place the belt. So you see that under the knee, you insert the lower part, and then you move it forward and set it in place at the level of the pelvic with the two osseous trochanter zipper. Then you buckle the strap and tighten it, and look at the way it is tightened. You need to be two rescuer to do that, because you have clearly to click the belt and to have a very high pressure on that. And then you use the Velcro to clip it. Now, another important point is that the two legs will be wrapped together, because if they move, they will reopen the pelvic fracture and increase the hematoma. So you wrap the two legs together, and then you check that the legs and the body are exactly on the same alignment. So I hope that you appreciate this small video. If it is a point that you like, we can produce a lot of video like that, and with our team explaining several points and several procedures or organization that may be interesting for you. So I will now show you quickly, because time is running, 2 points. The fact that we have also the way to organize this. The care we have seen before, the pre-hospital and before any surgical facility organization of damage control management of the patient is something that we have worked with in the French Army and also with the civilian EMS when we have a terrorist attack or very severe patient injured, looking like, in fact, victim of war. So I will explain you something that we developed. It's a simple mnemotechnic way of organizing the care from the scene to the evacuation to the hospital of a patient. And this is very important because if you are under fire or in a very dangerous situation, you have to be absolutely to have very clear in your mind all the action you have to do and do not have to think, just act as a reflex, as very quickly, act very efficiently. So this method is called SAFE, March, and Ryan. It's acronyms, most in French or in English. I will explain you that, but it gives you the possibility, the memory to have at each step of the management what you have to do and what you have to think about and what you have to organize. So the first idea is what we call the first phase. The acronym is SAFE, and each letter means something. And these 4 letters are clearly important action. You consider that you are under fire or in a very dangerous zone. That means a place you cannot control everything. So first, you have to try to stop the threat. If it is military operation, that means neutralize the danger of the aggressors. That means, for example, if there is a fire, to stop the fire and so on. And first, SAFE is stop the burning process. The second point is to assess the scene. That means to have a vision of what happens, in terms of what are you doing now, where are you, what are the resources around. Next point, if is free danger for you. And very important point is that when you are on scene, when you are near a place under fire, if you are injured, you just one more victim and you lose the capacity you have to save life. And that's the most important point. So the possibility is to stop the burning process, to assess the scene, but to free also the danger for you. Do not expose yourself because you are a precious value to the system. The next point is very important. And this one is evaluate victims on scene quickly. And there is a way that is extremely simple to triage quickly victims without medical means. It's the things we perform on only scene and groups of patients. First, you don't care of the patients that are walking. You just told them to go out to be in a safe position. Next point is that you clearly assess bleeding, breathing, bleeding, and consciousness. Very simple. 3 points. Are you breathing? Is it bleeding? Is consciousness? Yes or not? And then you identify among the patient, among the victims you have, the most severe. And this will be the one that you will take care in terms of immediate treatment at that time. If there is a single victim, no problem, you take care of the victim. But if you have several victims at the same time, the walking ones, they go out, you see later. The breathing one, they go out. If there is a bleeding, not bleeding, you go out. If they are conscious, they can go out, and so on, and you do that very quickly. You save time, and also you go out of this exclusion zone in order to make things more important. The second step is probably the most important. We will not develop it in detail today because I have told Dr. Oka that will be 45 minutes, 1 hour max of course today. But the aim is at each step of the second point to assess a situation, to take the emergency care procedures that is adapt, and to use medical equipment that may be or nothing or more sophisticated, depend the place you are and the facility you can use. All these points, if they interest you, we can develop them in further courses and have it made in details. The first letters of this acronym, March, the second phase in tactical care control, is controlling the bleeding, as we told in the principle of damage control. You search systematically for bleeding, and you will use the techniques we have seen as needed to stop the bleeding damage and so on, and we can go back if you want later on that. And you also have a look at the importance of blood losses. But if you don't look at the bleeding, you will be surprised that there will be an injury under the patient clothes or in a place you don't. You have to look precisely for that. The second point is that airway is open, yes or not. And the airway open is simple. Is air going through the mouth, yes or not? If it is not, that means you are in a very important emergency. If it is, the patient is breathing. Then breathing, assess the ventilation, how the victim breathes. And this is important in terms of, is it breathing normally? Is it breathing with a asymmetry? The fact that only half of the chest is breathing, and the fact also you have pressure in the vein and the jugular vein, because the enemy here is the tension pneumothorax we have seen before. And we have a very limited time to save the patient with a tension pneumothorax. The last point is C. The fourth point is C. C means shock in French, written like that. And again, simple measure to evaluate it. Radial pulse. Radial pulse, okay. Okay, not okay. That means the patient is bleeding. And you may have also other causes, for example, spinal trauma. We will see in another course, I think. When you arrive to the head, this is also very important. How quickly assess the neurological status of the victims in the middle of the field? It's simple. It's simple. First, is the patient, the victim alert? Can the victim talk, verbal? Does he feel pain or pain reaction or unresponsive? And you see the various level. The 2 points you have to check also is very simple. You look at the pupils and see if there is an anisocoria, because at that step, more particularly in patients with submitted to explosion and blast way, you may have the first sign of a cerebral hematoma, and then the paralysis of member. That means also a spinal injury most of the time, or one limb that can be injured peripherally. So this point, head troubles, anisocoria, and paralysis, then are important. The last point is, as we've seen before, hypothermia, prevention of hypothermia by all available means. That costs nothing, but this is extremely important. The last point is the evacuation. Is that you have the possibility to take the patient out of the scene on the field and should send it to a surgical facility. That's the time to do it. And if you have the initial management carry out for evacuation, multiple casualty, you take care of another victim if you have already treated the most severe one. You send the evacuation message, and during the evacuation, you have to evaluate other points that are less important, but that will be interesting. The fact that you reevaluate the patient during the evacuation care, during the transport, the fact that you take care of very special injury like the eyes injury, that you can do nothing out of a specialized center, but you set in place a special bandage for the eyes to protect the eyes. If the patient is suffering, you can then give analgesia and we see before that you have to limit the dose, but don't give a lot of analgesic without thinking. That not be a good choice. Also, you have to clean and prevent infection, which is very more simple. So that's the way. If you are interested in this method, we can comment this method in another course. We can explain you all the techniques and do that. We have been trained, all of us, all members of my team are able to teach you this. And if you want, that may be a possibility. I will now take 7 more minutes to a very important message. That's it's the update on the tourniquets we have seen before to stop the hemorrhage. And clearly, there is now a huge experience in tourniquets in victims of war, in casualties. And I want to share you data that have been published recently by John Holcomb. John Holcomb is an American surgeon that has done the Vietnam War, but he is one of the best men in thinking about the hospital environment as a surgeon. It's an out-of-hospital surgeon. And John Holcomb, I think you know it, Daniel, for you have met him a lot of time. It's clearly somebody that makes all his experience available to the whole world because he wants to save more life, and is probably one of the father of the damage control in modern surgery. So the war in Ukraine, it has been observed that a lot of victims of war have been evacuated with very prolonged time, and consequently, the EMTs, the rescuers that have been trained to apply them tourniquets, in fact, these tourniquets, they stay for several hours, more than 2 hours, 6 hours or more. And this delay in getting the tourniquet in place because they were unable to evacuate the patient has a huge and major morbidity, and probably a lot of victims have been amputated unnecessarily because, in fact, the tourniquet was not necessary to that time, and it creates a lot of ischemia. So there is now new recommendation for the use of tourniquet for everybody. And this is go against the myths of the tourniquet that has been said during the time. For example, the tourniquet must be extremely tight and in the highest position as possible. No way. The tourniquet must be applied, and when you have set a tourniquet in place, you don't touch it. You wait for the surgeon, and the surgeon will take care of the tourniquet. If you do that, in some circumstances, the patient will have tourniquet for many, many hours, and that's very, very dangerous for the limbs. So the aim of reassessing the tourniquet or replacing, changing the place or replacing by another means of the tourniquet is really important to preserve the limb, because prolonged tourniquet used create a lot of ischemia and it increases the loss of the limb. To prevent the compartment syndrome means ischemia will develop a lot of pressure, and that's also very difficult to treat surgically. To prevent the reperfusion injury, unfortunately, if you set in place a tourniquet for 6 or 8 hours, you cannot remove it, because if you remove it, you have immediately a shock of the patient with acidosis, coagulopathy, renal failure, and so on. So if you have it, probably it will be the need for amputation done in surgical wards. And then sometimes the tourniquet is extremely difficult to support. It's discomfort and major pain. So you give a lot of pain medication to decrease the pain of the tourniquet, and in fact the tourniquet is no more necessary. So you see all these means. So these are the new recommendation. First of all, tourniquets are at the beginning, say, highest in the limb and very tight. This means you are in a very stressful situation, high threat, under fight. But as soon as possible, you reassess the tourniquet, and the tourniquet must be checked to be effective in controlling bleeding, and if needed, you remove the tourniquet and you apply the tourniquet a little nearer of the bleeding. You change the place of the tourniquet, and you have to check the tourniquet in all the cases before the second hour, in less than 2 hours. After 2 hours, if the tourniquet may be something very difficult to manage. The indication of the tourniquet conversion are simple. You may change the tourniquet for another bleeding control, for example, a direct pressure bandage, hemostatic agent, or closure of the wound, in case of these three conditions are met. The patient is no more in shock. It is possible to monitor the rebleeding. That means you take off the tourniquet and it bleeds, you can re-put the tourniquet. But if you can use another means, it will be better for the limbs. So you replace the tourniquet by another thing. It must be possible. If the tourniquet is not used to control bleeding for amputation, because if you are a complete amputation of the limb and the tourniquet just set to stop a major hemorrhage, no worry about the limb. The limb has already disappeared. The patient is intubated. So salving the limbs is no more a subject. Every effort must be done that a tourniquet be reassessed in 2 hours and can be controlled by other means. We'll see the tourniquet to control bleeding of this patient amputated. You cannot move it. The tourniquet will stay in place up to the operating room and no need to convert it. And if this tourniquet is in place for many times, no problem. If there is a limb under the tourniquet, too late for replacement if you are 6 hours away from the tourniquet placement. So the next point of this is simple. The tourniquet saves life. The tourniquet must be converted. The tourniquet must be controlled. And what we have seen in casualty injury, several patients received a tourniquet that was not needed because it was a bleeding injury that stopped bleeding spontaneously or with only a bandage. And this patient has the tourniquet for many hours, and then the limb was ischemic, and the amputation was the result of the tourniquet, not the result of the wound. That's the end of the course today. You will may have, I hope, next courses in a month or two, according to what Dr. Ocar may organize. So, Professor Loisance, I give you the chair now for the conclusion of this course.
Professor Carli, thank you so much for your very comprehensive presentation, and that's helpful. Now, I wonder, do you have time to receive the questions from the audience?
Indeed.
Yes. Okay. So, the audience, if you have any questions, could you please kindly raise your hand, and I will ask. If you find it difficult to ask in English, ask the question in Burmese, and we'll try to translate it for you. Thank you.
Professor Loisance, do you have any comment about my course by the time of waiting questions?
Excellent presentation, Pierre. Excellent because you look at the theory and at the practice. It is very important. Are there some questions from the audience? I don't.
No? So, Professor Giroux, have you got any comments, please? Thank you.
Oh, it was a very good presentation and very efficient for you. I hope we can continue like that with Pierre Carli and his team because it's very good and also 1 hour lecture is very good. No more, it's a good timing. So thank you very much, Pierre, for this excellent lecture, and maybe we can organize other lecture now.
Dr. Ocar, there are some remarks in the chat, but I'm unable to read it. So if maybe there will be question in the chat. You have checked it?
I have checked that they are not the question. It is about the attendance. So
No.
Thank you.
Okay.
No question.
I think it is. I'm psychiatrist by trade, so I'm nowhere near the emergency medicine, and I learned a lot today, Pierre. I think that's
Dr.
really
Waka,
helpful.
Dr. Waka, I think it's very important that you share the video with all
Yes,
the potential
of course.
participants.
Yes. So we have recorded that, and we will convert it
Very
into the
good.
YouTube, and we'll share among everyone as well. So to me, if I may suggest, if we can have another talk a month time, and then about the Safe March Ryan. So you mentioned about the March procedure. So if I may suggest, I think that will be a continuation. So today's presentations and the next one will be linking to each other. So
Yeah.
I think Safe March Ryan, and you already suggested that, and I would like to request that on behalf of others, because that will be really, really beneficiary for all of us.
Okay, that's also the point of view of my team. They told me we have prepared something, but clearly, if there is an important message, it's about the march, because we can explain in the march all the procedures you add to each letter. That means
Yes.
what will be the way to control the massive hemorrhage and check the various means you have. For example, what you do if you have the tension pneumothorax. How do you diagnose it, and what to do with very simple means and things like that. So if you consider this is relevant, I think it's important. And I will just add a comment. The fact that you are working in psychiatry is extremely important, because for this kind of patient, all the medical corps, all the medical healthcare providers, they have to share these techniques that are very simple. And for example, if you see a patient bleeding without the possibility of stopping it, if you can improvise a tourniquet, you save the life of the patient, and that's the first step for a good, after that, psychological discussion with him.
Thank you very much. I see no comment or questions from the audience, so I, I think today we can go to the end of the today's CME sessions. And can I request Professor Di Gozzi give us the closing remark, please?
No, it's I am very happy to organize this series of lecture, and for you, and the audience was quite good, because I saw there were 37 links, so maybe more people in the audience, and I hope it's very interesting for you. And I thank very much Pierre, Carli, and also Daniel Wazans to participate to this lecture, and we hope to continue in the future, and with a new lecture, maybe we say in 1 month or something.
Yes.
And we will give you the date for that. Thank you, and thank you, Wakar, to organize and to participate with us to this
Pleasure. It is a really good
lecture.
CME session, and I hope we all learned something today. And thank you very much, everyone. Please
Very
stay
good.
safe, and